Hello, everybody. Um, I'm Dr. Brian Blair. I'm an orthopedic sports medicine surgeon at OrthoSC, and we're giving these webinars to try to educate anybody really about specific orthopedic topics. One that's near and dear to my heart is the idea of joint preservation and restoration. I got to give some credit to one of my fellowship mentors, if you will, or a guy that trained us in fellowship, Doug Weiland. He's up in the upstate and is big into this area as well. And a lot of this talk comes from stuff he's presented and talks he's given as well. So I got to give him credit for a lot of this too. But so the idea of joint preservation and restoration, it's a big topic and covers a lot of a broad area of things. And so I'm going to try to just highlight some of it. Some of these slides are technical that I've given at meetings and stuff like that. So I don't want to get bogged down with the science, but try to kind of educate everybody on the makeup of our joints and how to preserve the joint. And when we have joint damage, how to try to restore function and keep the joints that we have for as long as we can. This talk isn't meant to solve every joint problem. I'm a joint preservationist by heart. I'm sports medicine trained. There's different fellowship pathways we can all take when we finish orthopedics. One of them is joint replacement, one of them is sports medicine, there's spine and trauma, and we're also subspecialized nowadays. So I'm sports medicine fellowship trained. And so I try to preserve people's joints as long as we can, but I also do joint replacements. So joint replacements are good operations. I'm not trying to take away from that. But there's a lot of people who out there who want to preserve the joints that we have, who either aren't ready for joint replacement or want other treatment alternatives. And this talk is to try to educate you on that. So I have no disclosures or financial relationships with any other companies that would affect me giving this talk. The picture on the right is the picture of a knee joint. And I put that on there is to explain what a normal healthy joint looks like. You have all this white, shiny, smooth cartilage. This is the end of the femur bone. And then, hope you can see my mouse. Lisa, let me know if you can't see the mouse, but and there's this tissue in between is meniscus. So the ends of the bone are covered in cartilage, and the meniscus is the cushion in your knee. But most of our joints, and we have many throughout our body, from our spine to fingers, elbows, shoulders, everything like that. And so that's what a normal joint looks like. So what are our overall goals? Well, the main reason we do any treatment in orthopedics is to decrease pain. Pain is our primary indicator of surgery, of treatment. Most patients that present to us are having pain. That's why they're in the office. And so most people want to decrease their pain or increase and sustain their level of function or activity level. So the focus of this is on the articular cartilage, the cartilage that lines the joints. And there's weight-bearing joints and non-weight-bearing joints. So for instance, the knees, the hips, the ankles are weight-bearing joints. When you take a single step, you put up to 3 to 6 times your body weight in your knee just walking. Running, you can put up to 9 times your body weight through your joint. So versus a shoulder, which is a really non-weight-bearing joint. And so, you get motion in the shoulder. We don't walk on our hands. I mean, you weight bear some when you lift and push and pull, but it's not a weight bearing joint like a hip, a knee, or an ankle. So this is a picture of kneecap cartilage. And this is commonly when I do arthroscopy on knees, you'll see this, it looks like we described it as kind of crab meat, right? And this does not look like that healthy, smooth cartilage on the previous slide. You can see how this is kind of chewed up, beat up, looks like somebody took a weed eater to it. That's what I tell people. Any kind of cartilage damage, I tell my patients all the time, we grade cartilage damage 1 to 4. And we term that arthritis. So, you know, when there's a crack in the cartilage, we think it's arthritis, and we tell patients that, and they freak out and think, oh my gosh, I need a joint replacement. That's not necessarily true, but we grade it from 1 to 4, 1 being in just a small crack in the bone, and 4 being the cartilage is gone and the bone is exposed. So 4 is usually the worst type. That's what people say, do I have bone-on-bone arthritis? It's because the cartilage is completely worn off and exposed the bone. And when bone touches bone, bone has the nerve endings, and that's what causes pain. This guy I'll talk about later, interesting article, is an orthopedic sports surgeon. He's out in California, I believe, and writes a lot about this stuff. Actually had his knee, someone performed knee arthroscopy on him while he was awake. They used local numbing medicine, and they went around the knee and squeezed and poked and prodded and wrote it was a great paper on what hurts in the knee. So I know it sounds crazy. It is crazy, but it was, you know, there's different things that hurt within the knee. Usually the cartilage itself, you know, when you poke on it, doesn't really hurt. It's the bone underneath where the pain comes from. So here's this picture on the right is a picture of what cartilage looks like under the microscope. It's a microscopic. So all of this thick stuff, the cartilage layer, say in the knee, for instance, it's one of the thickest parts, is around 2 to 4 millimeters thick, which isn't that big. And so hyaline cartilage refers to the cartilage that you see in the knee. And then down here, this is bone. And so there's different layers of cartilage, but not to get technical, but the white stuff we're seeing is this stuff. And then down below, all of this stuff is where you get into bone. And so, you know, that cartilage that was flaked off is all of this stuff. And so when this all goes, you can see where the bone is, and that's where the problems arise. So, you know, what we're trying to do is preserve the native cartilage, the stuff you're born with. Once, you know, it's the only cartilage you've got. Now there are things we can do, which I'll talk about later, but this normal hyaline cartilage that we are born with is like I tell people, once it's gone forever. And the whole area of joint preservation revolves around how do we restore hyaline cartilage, which is difficult, and restore this cartilage, right? That's the holy grail of cartilage orthopedics, is trying to restore this hyaline cartilage. So how do we do it? Who do we do it on? When do we do it? Which procedures do we have to do it? And, you know, what does the future hold? This is an ever-changing area in a hot topic area right now. So this is the guy I was talking about a second ago, Scott Dye. He talks about this envelope of function, and a guy that trained me in Dallas was big on this. And what it is, you know, our joints have this tipping point, right? There's all these zones where the homeostasis, meaning it's the zone where everything's happy, right? And once you get outside of this zone of happiness, problems start happening. And so the goal is to keep everybody in a happy place and keep your joint happy. And there are different ways to do that. And so joint pain is a result of bone, soft tissue, and cartilage overload. And so when you start overloading this, and one of these mechanisms, or either bone, the soft tissue, the cartilage start failing, you get out of the zone of homeostasis, and then you start getting trouble, mainly pain. So you have to respect this concept. And for me, scoping 18-year-old high school athlete's knee versus my 65-year-old that's got some arthritis in their knee, that's where this comes in. And I always tell my, 50, 60 plus crowd that if I scope your knee, it changes that internal environment of your knee, and your body has to get used to that. So for instance, if you have a knee arthroscopy for a tear in your meniscus and you have some loose cartilage and we go in there and clean that up, your bone then sees new stress after that, because we've removed part of that meniscus, not all of it. And you've had a procedure, and now your body's got to get used to that. And so people who have arthroscopy and a somewhat arthritic joint and they go out in a week or 2 weeks after that and start walking 5 miles a day, their bone then sees that stress, and you can get almost like a stress reaction in the bone, which can last for months and months and months, even up to a year. And so that's where the zone of homeostasis comes in, and this concept of this, treating people not only operatively, but in the post-operative period as well. It's really important to understand. You know, how many people I see who come in who've had E-scopes and they hurt and they hurt. I've been hurting for 6 months, and it's really, they get out of the zone of homeostasis and it starts them down a path that takes a while to get over. What happened there? I'll lose you guys. Okay. Lisa, are we good? Can you see that?
Yes, you're fine. Keep going.
Why we lost the full screen? Sorry guys, my screen changed. You're seeing my, anyway, you can still see the, okay. Sorry, it changed. So if you can, this is an MRI picture here on the left. And this is what I was talking about earlier, out of the zone of homeostasis. See this white stuff right here? This is a special MRI image, and it's like, tell people it's like a cartoon character. This cartoon, you know, when you see the, gets hit and the thumb is, you know, red and swelling, and this is an angry bone. This is a bone to me that has cartilage problems, and it's screaming pain, all this white stuff. That's stress in the bone. And so things we have to consider. There's a lot of stuff in joints, right? There's the cartilage like we talked about. There's the meniscus. When we're looking at people who have joint problems, we have to think of, do they have any joint instability? Are there other reasons that can cause arthritis? Common ones that we see are people who tear their ACL. Whether it's, you know how many people I see who, I get the story, you know, they're in their mid 40s. Oh, when I was in high school, I had an injury and twisted my knee. I heard a pop. It swelled a lot. I didn't do anything about it. And now I'm seeing them when they're, you know, 42, and they've got the knee of an 80-year-old person with horrible arthritis. And it's because they had that joint instability. They tore their ACL, and your ACL is very important in giving your knee stability. And so they live those years having instability of their joint, where their knee will shift and those ends of the bone will rub on each other, and they develop arthritis. It doesn't happen all the time, but it happens quite a bit. And so, you know, how much mobility do they have? People's alignment, especially, I keep going back to the knee, but people who are very bow-legged tend to wear the inside part of their knee. And the older we get, we tend to get more bow-legged. When we're born, we're a little more knock-kneed, or what's called valgus. And we tend to get like this, and then we tend to get more bow-legged as time goes on. So those are all things that we have to consider as well. So that's just in relation to the joint. Then comes factors to consider with the patient, right? And you know, we have to look at the patient's overall health. What are patient's goals? And you have to have realistic goals with this, right? It's joint preservation. This isn't taking an arthritic joint and making it an 18-year-old joint, right? And so we're trying to preserve the joint you've got, not trying to make your joint perfect. That's the ultimate goal, but we're trying to alleviate pain. So it's clearly defining goals, how committed are patients, because a lot of these treatments require a lot of time, a lot of effort, and a long rehabilitation process to get through. So it's, you know, patient expectations. Everyone wants the magic bullet, the single shot, and their pain to go away forever. But it takes a lot of work. And then, you know, the surgeon and what skill and tool set does that surgeon have? How much experience do they have with this? You know, or do they follow the literature? Do they keep up with the latest things? You know, this is constantly changing. And so those are other things to consider as well. And then developing a program, which is multimodal, right? It's not just the patient and the surgeon. It's physical therapy. You have supplements. You've got, I mean, it's wellness and a fitness program and the equipment. And so there's a lot that goes into it. A lot of different aspects of orthopedics, a lot of not just the physician and the patient, but there's a lot involved as well. So this can be crazy and complex, right? And so integrating all these pieces for us, you know, to make a successful program, and that's what it is to integrate all these pieces together. So chondroprotection, this just refers to how can we protect the cartilage, right? What are things you can do to prevent you from getting severe arthritis or cartilage damage, right? There's over 200 and something causes of arthritis. And a lot of it's genetic, right? And so people are like, well, what kind of arthritis do I have and how did I get it? Well, fortunately, a lot of it's genetic. A lot of us, I see a lot of traumatic, post-traumatic, like I said, ACL tears, people who are, you know, have had accidents when they were younger, and we think maybe something, you know, that initial, when somebody tears their ACL, it's a pretty violent thing to the cartilage. And does that set off some cascade that then takes many years to present itself over time that starts the cartilage damage? And, you know how many people I see who've had ACL tears, who had ACL reconstructions, who present later in life with an arthritic knee, and a lot of them do. And this is what we talk about, my mentors about, and, you know, but so there's different causes. And so, you know, ideally we want non-operative treatment options, and then there's operative treatment. Some things we need to treat surgically. Some we can avoid, you know, treat non-operatively without surgery, but, you know, and then earlier I alluded to this cartilage restoration. How do we restore cartilage? Most of the techniques we have nowadays form what's called fibrocartilage. So it's scar cartilage. You got to think of cartilage damage as, I tell people, it's like a pothole in a road, right? That pothole used to be filled and smooth like the cartilage. Once you have cartilage damage and you have this pothole, you need to try to fill the pothole in. And the best we have right now, most of the time, is what's called fibrocartilage, which is scar cartilage. It does the trick. It fills the hole, but it's still not as good as the stuff we're born with, the hyaline cartilage. So again, this is kind of what we're after. How do we restore cartilage that's gone or has been damaged? So can we delay, minimize degeneration and pain? So with this fate of articular cartilage, you know, once it's traumatized, how do we prevent it from getting further damage? Perhaps there's hope. That's what this is all about. So some of the ways that we can treat this without surgery. So there's simple things, just as bracing, right? Knee braces. I always get so many questions. Do braces work? Do braces work? Will a brace help this? The specific braces we use are called unloader braces. And in particular, think of a knee. A knee has 3 compartments. There's an inside compartment, an outside compartment, and your kneecap. In general, with arthritic joints, a stiff joint that doesn't move as well, people don't tolerate well. So if you know people who've had arthritis and they could straighten their knee all the way, it was straight. And then over time, it gets to where they can't straighten it and that knee bends. People don't tolerate that well. And so some people will have wear in, you know, just one part of the joint, and that's where these unloader braces come in. These are braces that help unload that part of a joint were, for instance, in your knees, where we use these most commonly, when you walk. So if you drew a line from a person's hip to their ankle, that's where they tend to bear weight. Most people who are bow-legged wear in the inside part of the knee. So what a brace does is you put this brace on, and when they step, it puts pressure this way to try to open up that part of the joint to unload the knee. So these can be successful. This malalignment of the knee is a risk factor for arthritis progression. So people who are really bow-legged bear more weight on the inside part of the knee. People who are more knock-kneed bear more weight on the outside of their knee, and this is a risk factor for developing arthritis. Strengthening exercises, despite what people think, exercise is really healthy for arthritic joints. It's great. And I tell people low impact exercise, things like the bike, pool, elliptical trainer, those things are great. Motion helps lubricate your joint. It's the weight bearing that tends to get people. And so motion's healthy. It's, I tell people, can I walk? Yes, any exercise is good, but walking or running with somebody who has bad knee arthritis is going to be make you a lot more symptomatic than, say, riding a bike, where it's putting less stress on the bone, but you're getting the motion. So I tell people bike, pool, elliptical trainer, things like that. So yeah, I saw we had a question on here about any exercises that will help my discomfort of my shoulder arthritis, right? You're a golfer and you love to garden. So, yeah, and so shoulder exercises, shoulder's different than a knee, right? We can't do unloader braces and things like that. But we have handouts that we give in the office to people, some general shoulder conditioning exercises that involve internal rotation, external rotation, and these kind of push-pull exercises using TheraBands. You see those little spongy bands you can hook to the door. And I tell people to do that as kind of part of your daily routine. It helps strengthen the muscles around your joint and can help. And so we can easily get you some of that stuff, exercises. So strengthening works, especially for instability. Strengthening the muscles around a joint help support the joint. So other stuff, oral supplements, this is a big one. There's a lot of, I always tell patients the supplement industry is a multi-billion-dollar industry that's not regulated, right? And so prescription drugs or things, that over-the-counter medication and things like that are usually FDA approved and go through study and peer review and things like that. Most of these supplements, it's not a regulated industry, so it's tough. And so there's stuff out there that works, and they have been studied. I'm not saying they're not studied. It's not as rigorous as other pharmaceutical drugs. And so, glucosamine, chondroitin sulfate, you see all these medications. Some of the studies, have shown some benefit in moderate to severe OA as osteoarthritis. It's not been shown to slow or decrease the progression. There's all kinds of stuff out there, but I tell people, especially, the glucosamine, chondroitin, stuff like that, I tell people try it maybe 2 to 4 weeks and then stop it. And if you stop it and notice your pain increases, then maybe it's working. But, is there a role for supplement? Sure. But again, there's not a ton of great science around it, but there's some. So I always tell people it's pills, shots, and surgery. The pills that we use, other than the supplements, are oral anti-inflammatory medications, right? So there's pain relievers and anti-inflammatories. Tylenol is a pain reliever. Anti-inflammatory medications, Advil, Aleve, Motrin, things like that, are anti-inflammatories. We use meloxicam, there's Celebrex, there's, they're all work on the same inflammatory cascade, maybe in different areas, but they all kind of do the same thing. So I tell people, find what works for you. The downsides of these are long-term use can cause, if a lot of people are on blood thinner, so it can thin your blood a little bit. It can cause GI upset, ulcers. It's metabolized. Usually the anti-inflammatories are metabolized by your kidney, whereas Tylenol is metabolized by your liver. So it can, you've had these people that have been taking high dose long-term anti-inflammatory medicines who damage their kidneys. So they're not without risk as well. And, a lot of these older people probably remember Vioxx that worked great, but, they had these warnings about increasing cardiac events in people. So anti-inflammatories aren't without risk, and you can use them as needed, but that's another non-operative tool that we have. Then we get into injectables, injections. I tell my patients, it's usually, there's steroid injections, which work. Steroid is an anti-inflammatory that we put locally in the joint. It helps to decrease pain and inflammation in the knee. Side effects of this, usually if you're diabetic, the steroid can make your blood sugars increase. So if I have somebody who's a poorly controlled diabetic with a high hemoglobin A1C, and they don't know what their blood sugars are and they don't test them, I won't do that because it can increase their blood sugar significantly. But steroid injections work, and those can be safely done usually about every 3 to 4 months. The other type of injections are the gel injections. This is the hyaluronic acid visco supplementation, or the gel shots. People, the Brewster cone, all that stuff, but that's what this refers to. These are based off the building blocks of your articular cartilage, and what they do is help lubricate your joint. I tell people when you get arthritis in any joint, you have a lot of friction. Friction tends to cause pain. So the theory behind these injections are they help coat the inside of the joint. It's like putting mineral oil on your hands to help decrease friction, thereby decreasing pain. Another question popped up. Hold on. Here's one. How do you recommend treating a patient with a history of AVN and joint pain? AVN refers to avascular necrosis. That means the blood supply to a joint, for whatever reason, has been lost. So, if a patient had muscle damage during hip replacement and is left with a crater near the hip, is there anything that can be done with this? If there's muscle damage, usually a muscle will atrophy. So first question, patient with AVN and joint pain. So avascular necrosis is when the blood supply gets lost to the hip or whatever joint. And then the blood supply comes from underneath the bone to supply the cartilage. That's what keeps the cartilage healthy. So when you lose the blood supply to the bone, the cartilage tends to die, and it'll crack and it'll break apart, and that's what arthritis is. And then it becomes arthritic. We treat it like any other arthritic joint with the same injections, things like that. And then if it gets so bad, then it's time for a joint replacement. So it's a type of arthritis. It can get more complicated than that depending on the joint and the age of the patient as far as treating avascular necrosis. But if it's a younger patient, yes, there are many different salvage procedures that can be done to save that joint. If it's an older patient, then it's treating the symptoms until you replace the joint. But the muscle damage, it's, once a muscle is damaged and it tends to atrophy, and that's probably what's causing that crater, there's not much that can repair that, unfortunately. Okay. Back to, okay. How long do I have to wait between injections, and when should I start feeling better? So back to this gel shot. So this usually is every 6 months. You can do it twice a year. How much benefit will you get from it? It's difficult to say. I tell people you don't know until you try it. Some people love it and it works great. Some people it doesn't do that much for. And so there's some studies out there say, does it work better and longer than cortisone? Maybe. The steroid shots, usually it's every 3 to 4 months. The gel shots every 6 months. And, you know, I use this, I'll use it. It talks about post-arthroscopy. If you do, these are only FDA approved for knees, which makes no sense to me because arthritis is arthritis regardless of the joint, right? But they're only approved for knees. And so have we used them in other joints? Yes. I've used them in shoulders, but it's only approved for knees. And usually, you know, this post-arthroscopy, if my 60-year-old, if I scope their knee and they have a little arthritis, and then we'll usually inject their knee 6 or 8 weeks after surgery, and it tends to help. And so that's the gel shot. So I always tell people it's like putting WD-40 in your joints. That's really what it's like. It helps just decrease friction. It's, you know, the gel shots are viscoelastic. They will help maybe with shock absorption, mainly with lubrication. These cytokines, and I'll get to in a minute, are factors that help decrease inflammation. And does it help somehow protect the cartilage? Maybe at the cellular level. But they did one study using a dog model after taking out a meniscus that decreased the amount of inflammation and scar tissue in a knee. But that was in a dog. You know, this traumatized cartilage is what we're talking about. See this kind of just little fraying cartilage where it's not down to bone. So that, you know, we put these gel shots in there to try to decrease the friction there. This is, you know, what does the future hold as far as this goes? This talks about different antibodies against these. TNF is called a tumor necrosis factor. These are things that help using basically antibody type treatments to help deal with arthritis is the best way you can put it. You know, to try to inhibit the inflammation before it starts or inhibit the cartilage damage by this tumor necrosis factor. And there's antioxidants and things like this that help, you know, are there ways that we can help protect the cartilage before it's being damaged? And that's currently stuff that's being looked at. Some question pop up. Is oral hyaluronic acid effective for joint pain? You know, this goes into the area of the unregulated, like glucosamine, chondroitin, supplement industry, things like that, right? Nothing that I've read about oral hyaluronic acid yet to make a difference. I mean, a lot of this is supplement related, and unfortunately it's trying it, stopping it, and if you notice your pain increases, then it can help. But so far, I haven't seen any science on it yet. Okay. Here's another one that came in. What about TENS units or massage? So TENS units are transcutaneous electrical nerve stimulation. You've seen these little pads that people put on and they're hooked wires to this little machine, and it helps stimulate your muscle. Yeah, I used to use TENS units all the time after surgery. People, you know, when I was doing my fellowship, people really enjoyed, you know, we like to do things that don't require narcotic medication for pain control. And people like TENS units. I'm a big fan of massage to help decrease muscle pain and function and things like that. So yeah, I think there's a role for those. Next, PRP or platelet-rich plasma. This one's near and dear to my heart. I've been doing this for many, many years, probably going on 10 years plus now. Again, this is another non-operative injectable. So I tell people we have steroid shots, we have gel shots, and we have orthobiologics. Orthobiologics means these biologic injections. Of those, there's platelet-rich plasma, there's bone marrow aspirate, there's amniotic fluid injections, there's all these different biologic injections that are basically deriving, I tell people it's taking advantage of the body's own ability to heal itself. I could do an entire, and I have a whole talk on PRP and these biologics in and of itself, but in a nutshell, you're taking advantage of your body's own ability in at the cellular level to try to heal, decrease inflammation, and repair itself. And that's what all these injections are about. And in the order of, we're big on cost containment and how much do things cost. I think PRP is the easiest, cheapest way, and then it gets more expensive from there when you're talking about non-operative things. And the bone marrow aspect is where you actually put this tube inside your bone marrow and take it out and inject the bone marrow aspect. The theory behind is those are your, quote, stem cells, or the cells that help produce all of these healthy cells that can then decrease pain and inflammation. And then the amniotic fluid injections are basically taking super concentrated version of platelet-rich plasma and injecting that into a joint to thereby decrease pain and inflammation. So what is PRP? Platelet-rich plasma is where you inject the blood and separate it into its components, which is whole blood and plasma. And so that plasma is filled with goodies, is the best way to describe it. There's all kinds of growth factors, healing factors, and there have actually been studies of this, and that you inject it into arthritic joints and it actually helps decrease pain. I've done thousands of them. It's not FDA approved, and I don't know why yet, because we have good science. Before we didn't have any science on it. Now we've got some pretty good science and level 1 studies that show that it works. And I've got hundreds of patients I've done this on who vouch for it and have had good pain relief. Again, this is temporary. I'd say the studies say on average around 6 months. I've got outliers of people that are greater than 6 months and some that are less. But most people have gotten some good benefit from the platelet-rich plasma therapy. And I've been doing it for years and years and years, and I have not changed the way I've done it. And I've not seen the need to go to the more expensive bone marrow aspirate, amniotic fluid models, because they're in the thousands of dollars. And if I'm getting good clinical results, doing something that we can do for hundreds of dollars, most people would rather pay hundreds of dollars, and until some science is out there to say the clinical result is better using the more expensive technique, then it's worth doing. But I've had patients come in who locally have been charged $4,000 to $5,000 for, quote, stem cell, when it wasn't really stem cells, that have been injected by other I don't know, the best way to put it is they're physicians, but they don't have experience. Remember, we say the physician in the tool bag. People see this as a money maker. A lot of people who are not properly trained to treat this kind of stuff. And so I've seen people that have in my office who've paid $5,000 plus to get injections like this for people who've had joint replacements that have already been in their body, who this stuff doesn't work for. This is for arthritic joints, pain and inflammation. And so you just have to be careful out there. There's a lot of people doing this stuff that probably shouldn't be doing it. But I'm not trying to, anyway, just, I hate when I see stuff like that, when people are, here's another question. Do you, this should be inject under fluoro. We use ultrasound for a lot of the injections. So in the office, we'll use ultrasound injections. If it's a hip, fluoro means under x-ray. So if it's a hip, those we do under x-ray, but most other joints, we routinely inject joints. So we'll use either ultrasound guidance. If it's a knee, you don't need anything, but yeah, so we do either ultrasound or x-ray. Another question, if your knee is bone on bone, will the PRP help, or can you do? I've done mildly arthritic joints to the worst looking arthritic joints you've ever seen with PRP. And I've had patients that swear by it. And I've got patients I've been treating for years who have, I always joke, I was like, this has hurt my joint replacement business, but that's a good thing, right? And I tell people it's, if it keeps you out of the operating room and you're happy and you keep the joint you've got, that's great. But yeah, I've got lots of patients who can vouch for this, who have done it, who've gotten good long-term clinical relief from it. So. Stem cells, we just kind of talked about. They said, well, it improved cartilage healing morphologically and histologically, consistent with either salt or hyaluronic acid. So this was a study that was done. Again, the stem cell, the theory behind the stem cells is, can you help heal, right? So there's a thought, does a stem cell help decrease pain and inflammation? Yeah, probably. Or can we regenerate to that hyaline cartilage, the normal cartilage that we have? It hasn't been proven yet, but that's kind of where things are going with this. Now, those are kind of non-operative things, no surgery. Sometimes it gets to the point where there are surgical reasons to operate on people who have cartilage problems. And so, like I talked about earlier, you have to have what's their mobility? Do they have instability problems? What's their alignment alike? Some people are, that don't have arthritis, that are really, really bow-legged or really, really knock-kneed. We can change their alignment. It's a big surgery where you go in and cut the bone and put plates on there, but you can correct that alignment before they have arthritis. Once you start getting bad arthritis, all bets are off with that. So, here's another one about, I get this a lot about PRP in spine surgery, right? So a lot of people know people with back problems. I'm one of them who've had injections, steroid injections in their back. And I think some of the spine guys are finally looking at doing some of these biologic injections in the spine. They should have been doing it a long time ago, but it's something to consider for sure, and I think needs to be studied 100%. Okay, so back to the operation stuff. So there's, a lot depends on the patient, the age of the patient. We can do transplant meniscus surgery, right? Where if usually this is a younger patient, like I've had a 22, 23-year-old girl who had a surgery before I saw her, who they'd taken out almost all of her meniscus because it was torn, doesn't have arthritis, has normal alignment, and you can go in there and transplant in a meniscus to then try to give them some shock absorption, because 30 plus years ago, if you had a meniscus tear, they'd go in and take the whole thing out. We know now not to do that because some of those people would come back earlier, with developing some earlier arthritis. And so now we just trim out the piece that's torn and not take the whole thing out. But you can transplant in meniscus. I've done that before. And in the right patient, it can be done. So then it was cartilage restoration techniques. And so again, you can't replace it, but you can hopefully try to restore cartilage, right? And there's different kinds of cartilage damage: degenerative, which is arthritis, meaning just kind of wear and tear. People who've been injured, there are people who can break off pieces of cartilage. A lot of times we'll see this in kids where they'll have kind of a shear injury where they knock off a piece of cartilage. And then here's a good picture down here. You can see normal cartilage and then exposed bone, right? And so arthritis, my older patient who's got arthritis all over their knee doesn't look like this. This tends to be the younger patient, right, who has an isolated, usually I'd say a dime quarter-sized lesion, and we'll get to what you can do with that. You can do what's called a microfracture. Osteochondritis dissecans, that refers what I was talking about earlier, when you lose some of the blood supply to the cartilage and a piece of the cartilage breaks off. A lot of times we see that in kids in different joints. Here's the microfracture. So the place I did my fellowship, the guy invented this. And so this is near and dear to my heart as well. It's kind of the first generation. Remember that picture I showed you in the previous slide where you've got an area that's worn down, you've got good cartilage all around it, and it's about the size of maybe a quarter or less. You can go in and drill holes in the bone. And when you drill holes in the bone, see how it bleeds? That blood will then fill the pothole in with scar cartilage. That's called fibrocartilage that we talked about earlier. Remember the blue stuff? And so this is kind of before, this is the after. It's not the normal cartilage we're born with, but it does the job, it fills in the pothole. This has been studied and studied and restudied and studied upon studied. And this is kind of the first line of defense. We tell people it's got good results, a good track record. If you do this in a part of your knee where you bear weight and walk, you can't walk on it for probably 6 or 8 weeks. I mean, it's a big recovery. This isn't good for people who have arthritis all over their knee. If they've got exposed bone all over, this is not going to work well for you. This is for small isolated lesions, usually in younger patients, but it does the trick. But you get the scar cartilage. So again, back to we're looking at how do we grow the real stuff versus the scar stuff. Haven't quite figured out that yet. So the first line, this is what it looks like to microfracture. We take this little tip and we tap it in and drill a bunch of little holes, space them apart. And this is kind of the original cell-based therapy that we use. That's what it looks like afterwards. And we try to get that bone to bleed and then let that fill in with scar cartilage. And this is these are kind of these stem cells that come in, form this clot over this area, and then it forms the fibrocartilage. But then it's around quarter size or less. You get any bigger than that, then this doesn't work as well. So again, this is cost effective, it's cheap, it's easy, it's quick. You drill some holes in there, it has a good track record, does well. That's kind of our first line of defense. If that doesn't work, and then you can combine this with other stuff like we talked about, those hyaluronic acid injections, PRP injections, things like that, you can hit afterwards as well. So there's a lot of study around this, you know, the future, what's the future in this? It's just, there are a lot of these bone morphogenic proteins and things like that, a lot of these scaffolds that we can lace cartilage cells on and implant in there. So this is a big area in cartilage restoration here too as well. So this is constantly being studied. There's other stuff, this autologous chondrocyte. So it's called ACI, autologous chondrocyte implantation. What that involves is, remember that hole we had earlier, you can take cartilage cells, put them in there, and then sew this patch around it and try to get those cartilage cells to grow cartilage. Again, this gets more expensive. If microfracture doesn't work, then we start talking about doing these other techniques. But first line of defense, usually for me, is always microfracture. It's usually for bigger lesions. Remember the ones we talked about earlier were about a quarter. You know, again, this is technically demanding, requires an open surgery. The microfracture surgery we do arthroscopically. Usually it's 2 operations. You have to go in and harvest some cartilage cells and they grow them and send it back to you. Then you reimplant them. But in the end, the results have shown to be equivocal or consistent with microfracture. So again, microfracture works, it's easy and it's cheap. And so we do more of that. Other stuff, they have these minced cartilage systems, and this is what's called a de novo graft. This was years ago, kind of more popular, where you transplant. It's actually neonatal chondrocytes that they get from babies, these neonatal babies, and they get their cartilage cells and then transplant them into cartilage defects. Again, trying to get to grow normal cartilage. And then there's the bigger lesions. We do what's called an Oates procedure, where it's, you can take chunks of cartilage, either from cadavers or from other parts of your body, areas of your knee where you don't necessarily weight bear, and you can take these plugs out and you can fill them into the plug of the hole. So this is what it looks like. We take these little grafts and then we fill them in the hole. So that's actually your own cartilage attached to bone. And so you can get these from cadavers or your self. So again, the future of this is, you know, the combination of growth factors and adding injections and things like that. It's a combination of all these different things to try to help fill in the pothole. So this is a summary. So we're trying to enhance the cellular, intra-articular, and extra-articular environments. We're trying to mesh these all into one. It's patient matched. It's a la carte. So everybody's different, right? Everybody's different on how they want to tackle this, how aggressive they want to be treating it versus, supplements, bracing, surgery. Cartilage can be preserved, protected, and restored. You want to get the joint back into the zone of homeostasis, know and grow our own toolbox on how to treat this thing. It's an ever evolving area. That's pretty much it. No, it's confusing, right? Clear as mud.